Hello and welcome to Yodo. I'm Dr. Cerbone, and today I'm going to do a book review on 50 studies every palliative care doctor should know, and I think some of you should know some of these studies as well. I'll put the information about the editors in the description box below. I want to make sure I give them credit, but I don't want to mutilate their names. This book is divided into 4 separate sections. The first section is on palliative care. The second section is about symptom assessment and management. The third section is on psychosocial aspects of care and communication. And then the last section is about end-of-life care and planning. Topics in section 1 of the book cover only a few palliative topics. There's not as many research items in that part of the book. And it's more about nurse-led palliative care and early palliative interventions for cancer patients. There's a study about benefits and optimal delivery, as well as the availability. And we know palliative medicine has become much more available in the more recent years, but it's still difficult to find a palliative specialist that is trained. Studies in this first section provide results that early support, early intervention, that palliative medicine can improve quality of life of both the patients as well as their loved ones and caregivers. There's decreased rates of depression, decreased utilization of the emergency department, shorter stays in the hospital with reported higher quality of life by the patients as well as their family members and their loved ones. And that's compared to patients that did not receive the early intervention or palliative care at all. Studies indicated that patients and families receiving palliative medicine evaluation and consultation earlier in the course did better over time with a decrease in their symptom burden. They had reports of higher quality of life over time than those that didn't get any palliative care. Because of early palliative intervention, one of the studies indicated that receiving that information and education covered specific topics, and they did that over specified visits. The first session focused on the process of adopting caregiver role, and that was more geared for the patient's loved ones as to providing the care, but also to the patient as to how to utilize and interact with their loved one providing that care. It also provided for patient understanding and learning problem-solving skills and symptoms that should be monitored for and how to interact with that person. The next session addressed the self-care of the patient as well as the caregiver. So each party got their own information and learned different topics about the same thing, but from a different viewpoint. And then the third session, the final session in this study, covered tactics to best utilize the support team, the decision-making process when initiating advanced care planning discussions. So each of these 3 sessions in this particular study was limited to 30 minutes or less. I think this was a great study. I really enjoyed the information they gathered out of that. After those initial 3 sessions that were completed, then they did phone follow-up. And a lot of the patients and family members in those studies completed the phone follow-up and stayed within the study. Another study in this section performed was about the survey conducted over 70 VA facilities covering inpatient and outpatient palliative consultation teams. This was a comparative study that reviewed excellence of care, spiritual support, emotional support of the veterans that were involved in the study. The outcomes indicated that involvement of the palliative care team has provided improved care, better outcomes for pain management, and assistance with funeral arrangement as well as post-death emotional support of the family members and loved ones of the veteran. Family reported that the patient that was involved in those studies, that those patients had a better understanding of the life-sustaining treatments, and the outcomes of those life-sustaining treatments was better understood by the patient as well as by the family, and it really assisted them in making those difficult decisions. There was another study that was, again, a nurse-led study that was telephone-based palliative care, offering advanced cancer patients an opportunity to participate in quality of life evaluation. They'd studied the intensity of those patients' symptoms, and the utilization of resources, and the patient's reported mood across the spectrum of the patient from early in the disease course and at the time of enrollment until late in the disease or at the time of the patient's passing. The patients completed baseline questionnaires at the time of enrollment, and then they did follow-up questionnaires at different designated intervals throughout the duration of that study. And the results again were very positive, demonstrating higher quality of life by the patients within the family's judgment and the patient's self-judgment, with decreased symptom burden and improved understanding of their disease process. Section 2 of the book has numerous studies evaluating symptom assessment and management. Topics covered anticipated symptoms, medications used, side effects, tolerance of the medications, as well as toxicity and the effectiveness of those medications. One study looked at changes in the last month of life, with symptoms being evaluated for well-being, fatigue, drowsiness, anxiety, depression, nausea or vomiting, shortness of breath, and pain. So they looked at a lot of different subjective complaints. And remember, subjective is the stuff that we feel that it's difficult for others to measure. Results of that particular study indicated that most patients preferred to have a better understanding of what's expected as their disease progresses. The loved ones want to have knowledge of what to watch for, as well as how to intervene and how to help their loved one, how to help the patient. Both patients and caregivers found it important to have education regarding those anticipated symptoms for identification and the management techniques. Many symptoms are subjective, and the study indicated that this improved level of understanding of symptoms and the awareness of those interventions that are available for those patients provided many patients that had those symptoms, they needed the same amount or less medication than the medications who did not receive the training and receive the information. So reports of anxiety and depression, as well as improved symptom management, were noted. Another study looked at the reversibility of delirium, and Palliative Care study revealed that nearly 90% of patients experience some form of delirium as end of life nears. The closer to the end of life, the greater the risk for delirium. Multiple contributing factors are noted, including uncontrolled pain, advanced patient age, the number of medications being used that are not symptom-driven medications. And that's an important designation because some medications are given, but they're not really to treat the patient's symptom. Common symptoms for the delirium are day-night reversal, restlessness, agitation, visual and auditory hallucinations are also common. Occurrence of delirium with the inability to reverse this delirium is associated with poor survival rates beyond 1 week. I'm sorry about my dog grunting in the background if you can hear that. Correlation with uncontrolled pain, anxiety, and restlessness is also present. This resulted in the understanding that as death approaches, delirium becomes more common, and it's very upsetting for family members. And sometimes patients realize that they don't have a good grasp of reality, and it can be upsetting for them as well. The closer to the end of life and the longer the delirium has lasted, the less reversible delirium becomes, and it can be very stressful for the patient as well as the family because management of those symptoms is important. One setting looked at the use of anxiolytics and antipsychotics for the management of delirium. And there was no correlation with the use of anxiolytics for the reversal of delirium, but it was a small study, but it did indicate that the antipsychotics were more likely to improve that patient's symptoms of delirium. And I just was doing a board study exam just before I taped this, and Haldol is an antipsychotic, but is actually a drug of choice for acute delirium when all of the interventions that, like fluids and pain and all of those things, oxygen, have been looked at and have been treated, and the person is at risk or placing others at risk. Haldol is the first drug of choice we should be reaching for. Anxiolytics don't carry a warning, a black box warning, but they don't show the improvement that Haldol does. So it's a definite risk-benefit ratio, and as end of life nears, it's an important topic to discuss with family members what we can do to help reduce that delirium. A study regarding opioid rotation supported evidence that opioid rotation has a positive effect on pain management. Opioid rotation is commonly used for patients at the end of life because it can decrease the side effects that are occurring from the current pain medication. Risk for toxic metabolite accumulation will decrease, as well as what's possibly happening with the patient becoming accommodated to that pain medication. Now, realize there's a limited number of opioids, so it's not like we're changing something every day, but sometimes we do an opioid rotation and patients have improved pain management. And I liken that to allergy medications. For somebody that's ever taken an allergy medication and you feel like whatever you have been taking the last 3 months or 6 months isn't working, and then you switch back to something else that you've tried and you think, this one is actually working better. I think opioid rotation is similar to that, but it results in the decreased need for escalation of the pain medication. There was a study regarding the use of oxygen for management of shortness of breath at the end of life. And shortness of breath, otherwise known as dyspnea, is a symptom that many patients suffer from as end of life nears. And it's not just limited to patients with lung conditions. Surprisingly, the use of supplemental oxygen did not significantly reduce the person's subjective sense of breathlessness. We check the pulse ox reading on people to see if they're low on oxygen, but many people feel short of breath and their pulse ox indicates that it's quite good. If a person's circulation isn't good or their hands are really cold, we're not going to get a good pulse ox reading anyway. So following pulse ox is not something that we typically do in palliative medicine or at end-of-life care because the readings are not reliable. When patients feel short of breath, that needs to be treated regardless of what it says on the pulse oximeter measure. So oxygen, of course, is used first line, and if the symptom management is not achieved, the second line of an opioid, typically morphine, is used next. The use of opioids, and particularly morphine, resulted in a decrease of symptoms of shortness of breath within 30 minutes, sometimes 45 minutes, of a very small dose. They remained at low doses. Sometimes they would escalate the dose to the lowest effective dose, but medications for just the sole symptom of shortness of breath without pain is typically managed with a very low dose of morphine. Dehydration was also evaluated in a different study. Dehydration concerns are very commonplace among patients and the caregivers. When patients near the end of life, their ability to take oral hydration declines. Oral hydration is still preferred over IV hydration, but their limited ability to swallow can sometimes interfere with their ability to keep up with the needed fluids. So providing limited amounts of IV hydration is preferred over aggressive IV hydration. The benefits include decreasing the person's pain, anxiety, but the risks include edema, gurgling sounds, increase in mucus, phlegm development, and increasing shortness of breath because sometimes that fluid, instead of staying in their blood vessels, can actually go to their lungs or the back of their throat, and it can be very uncomfortable for patients as well as their family members. So the results of this study indicated that if IV hydration is going to be used at the end of life, that it's judicious use of IV hydration. Oral hydration, again, remains the norm and remains to be preferred. One hotly debated topic for patients at the end of life is that of nutrition. Family members often cite survival and cultural beliefs regarding their principal reasons for wanting to choose the option for a patient to have tubes to be inserted to feed them at the end of life. Results from one post-stroke study included in the book indicated that feeding tubes might reduce mortality, but the patients typically had results of worse functional outcomes than those that did not receive the feeding tubes. They often had more pain, more anxiety, and more restlessness. Results of that study indicated that patients have to be evaluated on an individual basis and have ongoing discussions regarding feeding tubes. Supplemental nutrition for cancer patients undergoing chemotherapy is very different than for the results of the patients of a stroke study. They again need to be evaluated individually, but if patients are undergoing chemotherapy treatment and are unable to tolerate their oral food and fluid nutrition needs, they might receive benefit from limited amounts of tube feedings. Study results for patients with cognitive impairment was also included in the book, And these study results did not reveal any improved quality of life. Patients with advanced dementia of any cause suffered decrease in their functional abilities as well as decrease in their cognitive function. They also had loss of mobility, altered bowel habits, and an increase of their irritability. Not just like site irritability at the tube site, but irritability, they just didn't want to be around people and they were difficult to provide care to. Numerous studies indicate that feeding tubes at the end of life can increase the risk for patients to have aspiration, pain, GI upset, nausea, vomiting, diarrhea, weight changes. There was not a lot of improved cognition, but cognitive changes were noted. And they don't report improved function, and quality of life was not reported. So this is really surprising study results, and it goes along with what we talk with patients and families about feeding tubes, that it's a very individual matter to be discussed, and the recommendations may be surprising for you. Section 3 of the book covered studies regarding psychosocial aspects of care as well as communication. Studies included in this section regarded mood disorders such as anxiety, depression, dignity therapy for patients, addressing spirituality, and the difference of spirituality versus religiosity. So it's a fine line that divides those two, but they are not the same. They provided improved understanding for prognosis, trajectory, and the preference of learning about patient beliefs regarding the methods of disclosure of information, and they improved the patient and family satisfaction when that information was disclosed honestly, clearly, and empathetically. It was important to learn that patient expectations regarding chemotherapy can sometimes be misconstrued, and it's necessary for the oncologist and the patient to be communicating in the same way so that there's a clear message from the physician to the patient, and the patient is grasping that correctly. The patients indicated that they wanted that information provided honestly but compassionately. There was a study that supported patients with serious illness suffering from anxiety and depression, having concerns regarding their nearing end of life, how they wanted those the information provided to them and how they wanted management of those symptoms provided. Patients valued dignity therapy to allow them to have a sense of purpose, a sense of meaning. They wanted it understood how they wanted to live and how they wanted to die. Patients with serious illness want to be able to interact with others as their illness progresses in a meaningful manner. An overwhelming 80% of patients receiving dignity therapy found that this provided assistance to their care and meaning to their life. They reported a decrease in the level of hopelessness, a decrease in their desire for death, decrease in their anxiety, and decrease in their thoughts for self-harm. Study results indicated that when faced with their own mortality, patients were prone to develop spiritual and existential crisis, which makes sense to me. And intervention reduced those burdens. One of the greatest challenges facing palliative medicine is attending to the patients with these types of needs, because this typically goes beyond the scope of our conventional symptom distress management that physicians perform. There was a study regarding the differences between spirituality and religious beliefs, and understanding by the physician and the care team can help patients cope with their illness and disease burden as well as the other related stressors. There was a significant impact on the patient's physical, emotional, and cultural belief system by addressing these concerns, and it was a positive impact in the patient's life and their life experiences. Acknowledging and validating emotions, worries, and fears by the healthcare providers and family decreased the patient burden. Mental health assistance and intervention providing insight and support to the patient as well as to their loved ones was valued. Patients reported having improved ability to express and share their hidden secrets, concerns, and wishes, and all of that improved their well-being. The support study, and that's all caps of support, was initiated in 1989 and published in 1995. It was across 5 academic medical centers and involved nearly 5,000 patients. Palliative medicine was in its infancy in those days, and that early study was one of the studies that impacted palliative care programs across the nation. Results of this support study demonstrated that properly trained facilitators and well-educated clinicians are required for improved prognostication, of illness and improved communication of test results and trajectory of illness to patients. Having key personnel does benefit patients and families when they're faced with the end of life. And I know that's an old study, but it is a key study. Another important study evaluated communication of poor prognosis. And this study indicated that 80% of patients would like to know more about their disease process, the prognosis, and trajectory, although most patients admitted they are reluctant to ask. Patients in this study indicated that they look to their physician to initiate the topic discussion. Patients prefer that topics be offered at each visit with the opportunity to either accept or decline further information. When physicians are met with resistance, they need to encourage patients to appoint another individual to hear that information on their behalf if that information that's being provided is necessary to hear, but the patient is reluctant to have that information provided to them at that point. Sometimes physicians feel that this needs to be known, but the patient's like, I can't hear it, I can't bear it right now, but the patient has to have somebody that can hear that information on their behalf. News may be harsh, but delivering the information must be provided in a compassionate manner that's acceptable to the patient's level of understanding. Clinicians require proper communication skills training with education regarding prognostic discussions to be given in a sensitive and empathetic yet informative fashion. Patients' preferred information be provided in a matter-of-fact manner, noting that patients are not offended by clinicians' show of emotion. Prognosis in terms of general time frames such as weeks to months, days to weeks, hours to days is preferred over a specific time. You have 3 weeks or you have 6 months. So it is preferred to give those generalizations, and as a clinician, that works better for us because we don't have a crystal ball. Study results from this study also indicated that properly conducted prognostic discussions allow the opportunity to empower the patient and family to actively plan for the future. The last study in this particular section regarded the patient and family beliefs and attitudes regarding efficacy of chemotherapy. Results of this study indicated that patients with advanced cancer and their families may misinterpret the efficacy of the chemotherapy that's being offered. The study indicated that to have improved communication, there needs to be better understanding by the physician of what the patient is interpreting of their words. Percentages should be given, such as 20% or 50% or 80%, rather than a general statement such as, this is going to give you a good chance, or this is better than a glimmer of hope. We need to give them a little bit closer numbers of what those percentages are, even if it's a range of percentages, 10 to 30% or 70 to 80%, rather than just those vague terms. So improved communication between oncologist and patient is necessary in the final stages of chemotherapy for advanced cancer disease. The last section of the book covered areas regarding end-of-life care and planning, associations between completion of advanced directives, which I know we harp on a lot in this channel, and the quality at end of life. The studies in this section looked to see what was reported, how they evaluated it, and what was reported on quality of end of life. In one study, it found that patients find it important for disease prognosis and trajectory discussions to begin with the specialist managing that disease process. Conversations from the primary care provider were also very much appreciative. Goals of care conversations referred to specially trained palliative medicine physician teams was relied upon when those goals of care discussions became difficult. Sometimes very complex family situations or personalities are involved. Patients preferred conversations to be held over multiple visits rather than one single encounter. Specialists reported feeling pressure to remain reassuring and positive to the patient. They felt pressured to provide the most optimistic information. Patients indicated that they preferred to hear truthful information provided honestly with an accurate reflection of their health trajectory. Studies indicated that there is a direct correlation between the information provided understanding by the patient, as well as completion of the advance directives. Results of this study indicated that patients who are either unable or unwilling to discuss the information, these patients should be encouraged earlier in the process to elect a healthcare surrogate or as their designee to hear information and assist with decision making. The study recommended that patients have a healthcare surrogate to listen to the information and assist with those decisions based on the patient's lifestyle, value system, belief system, and cultural background that's most appropriate for them. The study noted that most patients prefer to make their own decisions. However, there are circumstances when the patients prefer others to make their decisions that they're hesitant to make. The study found that patients who provide their healthcare surrogate their belief system and perceptions regarding what suffering means to them and what quality of life means, what brings them daily joy, assisted the healthcare surrogate in making those difficult decisions. It provided significant guidance to the healthcare surrogate later on when difficult decisions were needed. There was a study that revealed patients that did not have any end-of-life discussions until crisis occurred, such as in a hospital setting, that these patients and families had lower scores for experiencing a high-quality end of life. They reported more suffering, more anxiety, more depression, and more fear that the healthcare system was withholding care. So those that had a better understanding earlier on had less anxiety, less depression, and less fears later on in the disease course. Evidence indicated that loved ones of the patients in this category had a lower understanding of the disease process and prognosis, as well as the trajectory, and did not feel they fully grasped the likely outcomes of life-sustaining treatments. These families felt that they had a lower ability to grasp the information because so much information was being provided in such a limited time, and they did not feel that they had enough time to process the information or accurately make those decisions. Families reported feeling rushed and needing to forestall decisions, electing for more aggressive measures in order to allow them more time for that decision-making process. This indicated that although aggressive end-of-life care may have fit with the values and goals of some patients with advanced disease, it was not the case for the majority of those patients and families. In retrospect, they would have chosen different things had they had different information provided at a different time. There was suspicion of the medical team. They were concerned that the time was running out and that if they had made a decision earlier, that the outcome would have been different. One study evaluated symptoms that appear at end of life that are very subtle. Some symptoms that appear at the end of life may escape evaluation by clinicians, and clinicians that have had minimal training in the end of life care may not notice certain things that indicate end of life is nearing. And some of the symptoms of distress may include breathing difficulties, discomfort, fatigue, delirium, and declining appetite. Breathing difficulties have been included with periods of apnea, respiration showing mandibular movement, appearance of Shane-Stoke-like breathing pattern. So there's overlap between breathing symptoms as well as some symptoms that might indicate pain, such as grunting, moaning, furrowed brow, grimacing, inability to close their eyes. Those have all been associated with pain, delirium, and anxiety. And properly trained clinicians can discern that amount. Sometimes patient families can tell he's in pain or she's more anxious and she's just not right, indicating that they have delirium. But other times families are just overwhelmed with what's happening around them, that they don't feel like they're in tune with the patient. So this indicated that nearing end of life should be evaluated by cognitive impairment evaluations and scoring scales, and this will help the clinicians improve their interpretation of the patient's symptoms for more appropriate symptom management. Several studies indicated evaluating factors considered by patients and families to be important at the end of life. Numerous studies by Steinhauer and his group have been completed with major attributes included in greater level of importance at the end of life, including pain and symptom management, preparation for the end of life, achieving a sense of completion about one's life, discussions about treatment preferences, being treated as a whole person, patient relationships with their loved ones as well as their healthcare professionals, not wanting to be a burden to their family or society. Some prioritize being able to help others, being able to pray, and some prioritized having funeral arrangements planned. There was a sense that many tried to express that they needed to have the feeling that their life was complete, and for some, dying at home was very important. It is important to notice that the physician and family members and patients do not all agree on the ranking of the importance of these various items, and it's different patient to patient. Family members stress the importance of focusing on the patient's value system. Patients preferred to have a sense of control, have their burdens relieved, and to find that relationships were strengthened and improved as end of life approached. Many comments included in this study consisted of the concept of a good death. A similar study by Singer and other evaluators assessing quality at the end of life found that results across 5 domains related to a good death. And those included receiving adequate pain and symptom management, avoiding inappropriate prolongation of the dying process, achieving a sense of control by the patient and their loved ones, relieving patient burden as well as the burden for the loved ones, and relationship strengthening. Many patients are concerned about how their loved ones are doing while they're busy dying. They're worried about their family members. Very touching. Findings of one study indicated that patients who received care by a hospice agency for a longer period than 45 days were more likely to be satisfied with the care received at the end of life than those that received hospice care for a shorter duration of time. And this study has been repeated multiple times, showing that a minimum of 45 days receiving hospice is necessary, and patients and families that have been delayed with receiving hospice care until the last few days of life do not receive the good care that patients that receive care for a longer period of time. Findings of another study indicated that patients who have died with a hospice agency had report of fewer unmet physical, emotional, and spiritual needs. Family and loved ones of the patients felt more supported, and that the patient received the highest quality of care possible at the end of life given their circumstances. The last few studies in the book were regarding perceptions of what patients and families want to know about hospice. The most important things they felt were to know what's the visit frequency of the hospice agency, what are the disciplines that provide the support, what are the payment methods that are accepted, and what level and frequency of practical support is provided within the home. The study concluded that determining a patient and family understanding and their belief system regarding hospice is a really good starting point. In summary, this book of 50 studies provides a vast array across the spectrum of palliative medicine. Some of the studies dated back to the early developmental years of palliative medicine as a specialty. Many provide the support to the growing body of evidence regarding symptom management, the importance of psychosocial care, improved communication with goal-oriented decision-making, and honest discussion of end-of-life care assistance for patients as well as the clinicians providing that care and their families. Several of these were formative studies that have guided and become the building blocks for our important specialty. Other studies have been modified and repeated in recent years to improve our understanding of what the patients need. This at-risk population is a really difficult subset of patients to evaluate, and we have to care for them and assess them carefully. They have high risks and very important concerns. We need a better understanding of the issues that patients nearing end of life face to develop appropriate methods to manage those symptoms. Helping patients and families at the end of life is really an important priority for me. As always, thank you for being here today. Thank you for listening, and I hope that I provided some information for you. This has been something that you found valuable. If there's something that you would like to be discussed, please drop it in a comment box below. Thank you for subscribing, and I'll see you real soon. Bye now.